Hello everyone and welcome to the August 2024 Medic Monthly video. This video was originally going to be EMS Ops, but with the fact that whole blood training was also going to be released, and that's about a 40-minute class, we didn't want the field providers to have to do a 40-minute whole blood familiarization and an hour Medic Monthly video. We all understand the amount of time and the commitment it takes to be able to sit down and watch an hour video each month, and we appreciate everyone, keeping up with it and doing it. So we decided to just switch things around a little bit, take that whole blood training, include it in the August Medic Monthly video so you only have to watch one presentation, and then next month we can kind of pick back up where we left off with EMS Ops. So this is going to be a trauma video covering specifically whole blood and hemorrhage. So for this video, there's only two topics. The first is going to be about 40 minutes of whole blood familiarization training. That training is going to be voiced by Josh Cook, but there was a whole bunch of people who came together to get that program up and running. The whole blood stuff, I was talking to a medic who's a DC paramedic, and he said that it was introduced in DC and it was actually a very huge positive change for the department. It's really, really good for patients. They've had nothing but good experiences and good things to say about it. So I'm excited for the whole blood to come into Montgomery County and for the patients of Montgomery County to get that level of treatment. So the first 40 minutes are going to be that. Last 20 minutes are going to be me covering hemorrhage, specifically how to stop the hemorrhage. So if we're going to go over, putting blood into people, we're going to go over how to stop blood from coming out of people as well. So nothing groundbreaking there, just a review on some bleeding control and some of the other ALS medications that kind of go hand in hand with whole blood. So the monthly videos are constantly evolving, and somebody came to me with a great idea saying, hey, we probably get, 10 to 20 emails a month that pertain to EMS or pertain to EMS changes, right? There's constantly sticking points and just emails from duty officers, battalion chiefs about EMS. And it's easy, even if you're very attentive to your email, to miss something. So why don't we add a one slider at the beginning of each monthly video that kind of covers the changes in Montgomery County EMS over the past month? So that's what we're going to start doing, and here's the one for this month. So couple points very quickly. Cardizem can now be given either via the pump or slow IV push. So basically, direct, defendable, communicated, make a decision, what's best for the patient. If proximity to the hospital or whatever it may be makes it so that IV push is the better route, go for it. Just emphasis on slow IV push because you can really bottom out their blood pressure if you give it too fast. So that's a change. Kind of just a review point is that while the Cardizem dose for patients above 50 is that 5 to 10 initial bolus, it's just an initial bolus, and if it's well tolerated, you can then move on and give the 0.25 mg per kg to a max of 20 secondary dose, that weight-based dose, if they tolerate the initial 10 milligram bolus well. Obviously, proximity to the hospital sometimes might not allow that second bolus to take place, but you do have that ability to give it if you want and if they respond well to it. The pediatric epi infusions are going to be weight-based now, so as you're setting up the epi infusion on the pump, it's going to prompt you to put in a weight. Remember, we have HandTevi, ask the parents, that type of thing. Epinephrine infusions are the only medication used for the treatment of pediatric shock per the Maryland medical protocol. That's just referring to the fact that we do not use norepinephrine, Levophed, for pediatric patients. It's an adult-only medicine. Air, just another reminder, the air alarms on those Sapphire IV pumps are disabled now. So you have to be very, very attentive with the air in your line and the air in the bag. We should be burping the bags prior to putting them on the pumps. That pump is not monitoring for air, so you have to do it in place of the pump. Finally, documentation of dual sequential and vector change defibrillations. Just remember that when you import from the monitor or import from HandTevi, it's going to give you all defibrillations as just the regular defibrillation code. You need to go back in, count 3 shocks down, and then on your 4th shock, whether you did dual sequential or vector change, alternate and put in that you did that alternative defibrillation technique, and continue to edit the rest of the defibrillations to show that you did dual sequential or vector change throughout the rest of the code. That'll save you an email from EMS QA or QI. They don't know what you did on a call if you don't document it. So if you documented 12 regular defibrillations, they're going to reach out to you. So just an easy way to avoid an email, make sure your defibs are documented appropriately.
Hello and welcome. My name is Joshua Cook, and today we'll be talking about your role as a field medic in the implementation of the low titer O positive whole blood in MCFRS. Before jumping into the class, we need to thank the people that made this possible. Our medical director, Dr. Roger Stone, Assistant Chief Tim Burns, Battalion Chief Ben Kaufman, and Master Firefighter Paramedic Alex Gunnarsson. Many thanks to the Howard County Division of Fire and Rescue Service for their assistance in the development of our own program, and this would not be possible without the partnership with Suburban Hospital and Inova Blood Service. In today's class, we're going to be talking about 4 main learning objectives. Why are we deploying whole blood? Why are we using low titer O positive whole blood? What hemolytic reactions are possible? And how are we implementing this in the MCFRS EMS model? So why whole blood? This video with Colonel John Holcomb will explain some of the history behind whole blood and why we should be using this as our premier resuscitation product, especially in trauma and hemorrhagic shock.
So I was asked to talk a little bit on background of Mildasiv on whole blood. Many of us enjoy history. The first recorded use in the U.S. military that I can find was from the Civil War, with a small transfusion, a couple ounces actually, of whole blood from a healthy German to a Southern casualty who had an amputation. The patient lived. The surgeon who did the transfusion ended up being the chairman of surgery at the University of Arkansas, and then the dean, which is where I went to medical school. How about that? For loop closure. And and then, of course, World War I really exploded the use of whole blood. World War II, even more so. Unfortunately, by the time middle of Vietnam came around, whole blood was falling out of favor to component use. Component use came into being without any, what we would consider today, high-quality data, suggesting that it was at least as good as or better than components. There was no data suggesting that. It was more of a convenience factor, ability to sell multiple components, and the need driven by chemotherapy, where patients needed platelets and no other components. So there were many reasons why that switch happened in the mid-70s, none of it data-driven. If you kind of move forward a little bit, and some of us who have gray hair lived through the era of crystalloid 10 to 20 liters, then red cells, and then a little bit of plasma, and hardly any platelets. Those patients didn't do well. They had multi-organ failure, abdominal compartment syndrome, compartment syndromes throughout their entire body, actually, and on and on. And then now you move forward to several wars. My first experience with whole blood was in 1993 in Somalia, where a third of the hospital donated whole blood. We gave it to really sick casualties, and they did remarkably well. It was incredible, the resolution of coagulopathy and how well the patients did. And then you move forward. That didn't go over very well when we spoke to blood bankers around the country in the mid to late 90s. So we started working on ratios, and that ended up being the balanced transfusion that you guys are familiar with in the hospital. And of course, the ultimate balanced transfusion is whole blood. And so if you kind of work your way through that logic, you end up with whole blood. Whole blood is now, these are data that just came out of TQIP just the other day, in 50% of the level 1 and 2 trauma centers that submit data to TQIP, which is about 500 hospitals, I believe, 50% now have whole blood available. And so really the real issue in my mind is to make whole blood available pre-hospital. If you look at the data, I'll go to the second part of the discussion now, Peter. If you look at the data that's been published, in the New England Journal, in really high quality, the best journals around with high quality data, blood product resuscitation of patients in hemorrhagic shock is superior to crystalloid resuscitation. There's no question about that. Now, if you translate what we've learned from the hospital to the pre-hospital area, and I recognize what I'm saying here, then whole blood should be better than components as well. because it is the ultimate balanced transfusion. It's easier to do balanced transfusion, and it has platelets in it in addition to, of course, the plasma proteins, which include fibrinogen and the red cells. So I think the data are highly suggestive that whole blood pre-hospital is a superior product to components, and I know that components are superior to crystalloid. Now,
Let me ask you a question.
For any questions.
Yeah, so the question I have for you is where are we right now in the, because there's still people who are kind of watching and waiting, if you will, and you had the refill trial that showed maybe not the best outcomes. Where do you think we are, and where do you have to be? And I'm kind of, I don't want to bury the headline here, but later we have Dr. Duchesne and Danielle Tatum. Dr. Tatum will talk about the data, but where do you think we are today, and where do you think we have to go to prove this out?
Yeah, so, changing practice is very interesting. And as Paul mentioned before, we've kind of done that with tourniquets. We've done that with blood products in the hospital. It's now standard of care to give a balanced resuscitation. You have to have some data. I think you have to have some common sense and logistical, at least equivalence. The cost comes in there as well. There are, and then you have kind of people that are early adopters, and then you have the Luddites on the other end, and kind of the curve in between. So there are whole blood studies around the country, starting in the hospital, prospective and randomized multi-center whole blood studies funded by the NIH. The DoD is funding a prospective randomized pre-hospital whole blood study, multi-center. The French have a whole blood study that is starting, and as well as in the UK. So there are multiple well-designed, I would call phase 2B3 studies that we will have those New England Journal JAMA type data in 3 to 5 years. Until then, I will just until then, I like to be data driven as much as possible, but I also I try to be practical. If my son is 21 years old, he's kind of a bonehead. He does boneheaded 21-year-old things. My daughter is much more careful. If my son gets in a car crash, or hang gliding or jumping out of an airplane accident, I want him resuscitated with whole blood.
In these past couple of years, we've done a lot with instituting Stop the Bleed programs and teaching tech classes within the department, but those only focus on stopping hemorrhage, not replacing the blood that was lost. They also focus solely on external injuries where we can stop the bleeding, but when it comes to internal injuries, we have no way to stop those bleeds, so whole blood transfusion is going to be our best intervention. So, like we said before, despite some of the awesome advances in trauma care in the past 30 years, trauma is still the leading cause of death. This is especially apparent in young, for those aged 1 to 44 years old. Trauma is number one cause of death. 40% is from hemorrhage. At some point during your paramedic education or EMT education or even your continuing education, you've probably heard of the golden hour. It's a pretty poignant term in most of our minds when it comes to trauma patients. And in this journal from 2016, Time is the Enemy of Mortality in trauma patients with hemorrhage from torso injuries occurs long before the golden hour. So this takes a look at, does the golden hour play into effect, and is there other things outside of that golden hour? And part of it is that, yes, transporting patients to a trauma center and surgical care in 60 minutes or less does help save lives. But not all critically injured patients will live for 60 minutes without hemorrhage control and blood. So this is showing that while, yes, this golden hour does exist, there are a subset of patients within that the golden hour is too long, where administering blood products will extend out the amount of time that this patient has to get to a definitive treatment facility, a trauma center. And to a point of fact, the first 10 to 15 minutes post-injury is where we can affect the most change. That's going to be when we're getting on scene, determining what is needed for this patient, doing our critical interventions, and then determining when to start transport. And then in the future, with whole blood, when we're going to be initiating that whole blood when it's indicated. So in the past 7 to 8 years, there's been a large boom in EMS blood programs developing around the nation. Starting in San Antonio in 2017, this is the first pre-hospital blood program in the U.S. It starts in Houston and San Antonio in that greater region around San Antonio. Then in 2019 and 2020, the Virginia side of the COG starts with their programs. Fairfax is still coming online. In 2022, the Florida EMS Whole Blood Coalition begins deployment and a nationwide education. We'll hear more from one of those jurisdictions in a moment about their success. In 2022, Pittsburgh EMS is the first in the U.S. to have whole blood on individual ambulances. In 2023, Maryland State Police Aviation deployed blood on their aircraft, and then Howard County became the first ground jurisdiction to deploy in late 2023. A short time after Howard County implemented their inaugural program, Dr. Levy and his colleagues worked on this concept paper just published weeks ago, highlighting 4 pillars for building success based on best practices. You'll note that we in MCFRS are incorporating some of these principles into the 4 areas of this discussion that I mentioned in the learning objectives.
So this is the BSO data. So I want to just talk about who is actually receiving whole blood from BSO. Most of us are giving MVAs and gunshot wounds take up the majority of our trauma. And then who's giving it? It's our Air Rescue 85 was the majority. But I'll tell you, we have a ground unit, EMS 17, which is our EMS captains, and they do a tremendous job, and they're giving more and more whole blood and doing a phenomenal job. I do want to take a moment because our program would not be successful if it wasn't for Air Rescue 85, the EMS captains, and Lieutenant Kravanek. These folks are just incredible. I mean, what they do and the way they push this blood and just they've become experts in this. So I'm so honored just to be a part of their team. The next slide to talk about, this is compelling data, and I really want you to take a look at this. Let me define a couple of things before I get going. First is defining survivability. We use 24 hours, so if they survive to 24 hours in the hospital, the shock index is heart rate over systolic blood pressure, for those that don't know that. And then the way we captured this is the actual first set of vital signs. So this isn't necessarily as they subsequently developed. Worsening vital signs is the initial vital signs. So as you can see, and one would expect, the patients that we give whole blood that are already in cardiac arrest, only 1 out of 21 survived, and we would expect that. If you look at class 1, so they came and they essentially had normal vital signs initially, 50% of those survived. And then if you look at class 2, which is a shock index between 0.6 and 1, 18 out of 18, we had 100% of those patients survive, which is astonishing. And then the next category is class 3 shock, and here you can see 90% of those patients, 9 out of 10, survived to 24 hours. The most astonishing really is class 4. These are the worst, the sickest of the sick in traumatic shock with a shock index above 1.4. And 100%, 23 out of 23 have survived at the 24-hour mark. So I find that to be really incredible, and it really makes you see what the people that are on the ground, as I mentioned, Air Rescue, the captains, lieutenant, they are so moved by what's happened here and you can see it here in the data. So it's really compelling.
Yeah, nice to see all of you guys. I wish we'll be everybody in the same place, but it's great to do this. So definitely it's time to do a formal registry. I believe there is so much we can learn from what everybody's doing independently. And in 2021, we put a study together about 800 MTPs done in Charity Hospital, University Medical Center, just to see how we were doing with resuscitation and moving the pendulum. So this is the kind of patients that we were dealing with. And to our surprise, and this was published in Shock Journal, we basically demonstrated that mortality also went up and down, was basically consistently 7%, of which tourniquet and whole blood were the ones that were sending some kind of signal of improved survival. Later on, the next year, we presented the impact of time to surgery on mortality in hypotensive patients, and this was a AAST multicenter study. And basically, not to anybody's surprise, as we know, non-compressible thoracic hemorrhage patients die within the first 30 minutes. And as we know, we have the golden hour, 60 minutes for decoration purposes only. And as we demonstrated, basically it takes 30 minutes for these kind of patients to arrive to our trauma centers. And from there, it took on average 74 to 88 minutes to get a hypotensive patient that is bleeding from the torso to get to the OR. So based on that, we start putting our brains together and start thinking, what can we do better to move this pendulum of resuscitation? As everybody, some of the old school brain cells out there, they said that the only thing that the ambulance needs is diesel. Well, I think it's time to move that pendulum, because that's definitely wrong. We haven't moved the mortality curve doing that. And because of that, we've been pushing for not only stopping the hemorrhage on the spot with tourniquets, but we will need to start thinking about circulation first as well. And as everybody knows, it's been published by PAMPER trial and combat casualties that the administration of blood products before arriving to the formal destinations had improved definitely life and saved lives. The same thing based on the PAMPER trial. So why I'm doing this? The main reason why I decided to do this and to push for pre-hospital blood, specifically in New Orleans, is because of this specific study, because I was so excited when this came out, but I was so frustrated with the outcomes. And this is the reason why we're doing this, because I believe that there's many other ways to improve these outcomes. So we started our program, or actually the whole get-together pre-COVID, believe it or not. And we started thinking about how we're going to get the blood products, who was going to be giving us the blood. And this is basically what we decided to go with. With New Orleans CMS, we worked hand in hand, and the goal was to give 2 units of packed red blood cells with 2 of calcium and 2 TXA. We did advanced resuscitative education to all the medics of New Orleans CMS. It took us 2 days. It was very nice and collaborative. And this was the first tool that we used for database in the pre-hospital setting. And then from that, we started getting some information that was really cool. The average time to administration in a fast-paced urban setting was 8.6 minutes. So far, we've given 175 total units. We actually predicted 92 units for a year span, and we surpassed that. The average volume of administration was 552 mLs per patient. When we compare on the scene versus en route, most of the patients received the first unit on the scene and the rest on route. And this is one of the first things that we actually demonstrated. We've been demonstrating is that there's a big difference in the shock index on the when the medics arrive, from 0.95 blood given arrived to the hospital at 0.6.
So let's do a quick review on the ABO system and blood types. So people with type A blood have the antigen A on the surface of their red blood cells, as you see on that top left graphic. They have B antibodies in the plasma. This means that they can receive anything that's A, but they will attack anything else that has B. People with type B blood have the B antigen, as you see in that top right graphic, and they have A antibodies in their plasma, meaning that they will attack any A type blood. People with AB have both A and B antigens and have no antibodies in plasma, meaning that they will have no reaction to any type of blood. And people with type O have no antigens present, but both A and B antibodies in their plasma. So just for a quick review, antigens allow our immune system to differentiate between foreign invaders from our body's own tissues. Antibodies recognize invaders and mark them for destruction by white blood cells. One may think of antibodies as a target identifier that highlights specific antigens and triggers the immune response. Some immune responses are beneficial, but others can be very dangerous, like anaphylaxis. So why low titer O positive whole blood, or LTO positive WB. So we're going to break it down by the name of it. So low titer. This is going to, the complete product contains low levels of antibodies, making it safe to transfuse to the patient with any blood type. That's where that O portion comes into play. O can go to all patients, and with it being low titer and O positive, as we'll talk about in a second, it makes it very easy to transfuse without any reaction. So the type O positive. Yes, type O negative is known as the universal donor, but there's very few of these people in the world, as we'll see in a future slide. 82% of the patients of the population is Rh positive, which means that us giving to Rh positive blood types is going to be much easier. And then there is a large amount of O positive donors out there, making this easy to build a stockpile of this blood and use it. Then whole blood, it contains all the components we need: red blood cells, plasma, and platelets, making it the best resuscitative product that we can give. So a quick breakdown on the percentage of blood types. First and foremost, we want to talk about who can go to what. And over here on the left, you do see that AB positive is the universal receiver, but we're not too worried about AB positive right now. And then you'll see that overall, O negative is the universal donor. But what we want to focus on is the O portion of that. So if you look at the graph on the right, you're going to see a breakdown of percentage by blood type of the U.S. population. The largest amount is O positive at 37%. So that type O blood is important here. And as we said on the previous slide, that positive, so it's a Rh factor, meaning that we can give to the majority of people that are positive. And if you look, as it breaks down, there are more positive people, as we said before, about 82%, than negative people. So we want to be pulling from that O positive. It's a readily available stockpile of blood because it's the large amount of people in the United States, and it's going to work with the majority of people that we give it to without any risk of transfusion reaction. So we're going to do a quick overview of Rh factor. The positive or negative sign next to the blood group is known as the rhesus factor, or Rh. The Rh factor is an antigen that can be found on the surface of the red blood cell, just like A or B antigens. If your blood type is positive, then your blood cells have the Rh protein. And if your blood type is negative, then your blood cells lack that Rh protein. So someone with Rh positive blood can receive both Rh positive and Rh negative transfusions, but those with Rh negative may have a mild reaction to Rh positive blood. But that's okay, and it's also extremely rare, since most of the people that we are going to be transfusing to are going to be positive. The body's response to an Rh incompatibility is much weaker than the ABO system incompatibility, meaning giving Rh positive to Rh negative is okay compared to giving a type A blood to a type B person. A concern that is brought up typically with whole blood is the risk that it poses to females who are Rh negative and have childbearing potential. Remember, whole blood that we're going to be giving is going to be O positive due to the emergent setting it's being given. The risk people are worried about is that an Rh negative female receiving a blood transfusion containing Rh positive antigen and then producing antibodies that could later harm a fetus that is Rh positive in the future. There's only about 20% chance that this person or this pregnant female will be exposed to those antibodies, and overall there's only about a 6% chance she will develop a life-threatening condition to her baby. When polled, most women, when asked if they would receive blood to save their life with the possibility of it causing a reaction with a future fetus, voted to have the blood administered to them instead of that possible further risk. So you'll find in the Maryland Medical Protocols in the whole blood protocol that there is a section dedicated to transfusion reactions. So some things to look for when giving a whole blood transfusion are hives or itching, wheezing, rigors and or fever, shortness of breath, facial flushing, abdominal pain, vomiting, and sudden worsening hemodynamics. If you see this and you suspect a transfusion reaction, you should immediately discontinue the transfusion, administer dexamethasone IVIO and Benadryl IVIO in age-appropriate doses. A new transfusion from a different unit of LTO positive whole blood may be initiated if patient reassessment indicates continued need for blood. The end all of this is that this patient still needs blood, and we're going to ensure that we're able to do this safely and efficiently, even though we had this transfusion reaction before. So even with the possibility of transfusion reaction, there's even a smaller possibility of an anaphylactic reaction to this blood transfusion. Despite O blood type having no A or B antigens, a small number of patients may have this reaction to LTO positive WB, low titer O positive whole blood. Signs and symptoms will include the same as allergic reaction, anaphylaxis, and if we do suspect that, we need to stop the transfusion immediately and treat per protocol. When it comes to specifically handling the bag of blood that was being used, disconnect the line so no residual blood left in the tubing is given to the patient. Consult to the receiving facility of the possible transfusion reaction. After the transfusion is stopped, all blood tubing and the blood bag itself should be placed in a marked Ziploc bag and brought with the patient to the hospital. Do not throw it out. The EMS duty officer that will be riding with you will be well trained in this and will understand the procedure that needs to happen with the actual equipment. So now how are we going to implement this within our own system in MCFRS? So everything that's going to be concerning how we go about implementing giving whole blood is going to be found in the Maryland Medical Protocols under the 14.6 pilot protocol, low titer O positive whole blood transfusion. So the indications are going to be clinical suspicion for major blood loss with evidence of significant physiological compromise. So the mechanisms or nature of illnesses that we're going to be looking for are going to be a clinical suspicion of a blood loss such as penetrating trauma to the trunk, unstable pelvic fracture or multiple long bone fractures, blunt trauma mechanism consistent with major internal blood loss, observed major external blood loss, and signs and symptoms of massive GI bleed, ruptured aortic aneurysm, or ruptured ectopic pregnancy. We're going to assume hypotension and tachycardia in these cases is due to major trauma and blood loss unless there's an obvious alternative reason. So be looking at your patient as a whole. So once we have this indication, we're also going to be looking for some physiological compromise. So first and foremost, age-defined hypotension, which you can find outlined within the protocol, and then plus at least one of the following: age-defined tachycardia, end-tidal CO2 less than 25, a positive EFAS exam if available. That will not be part of the Montgomery County rollout. We are not doing EFAS exams currently. A lactate greater than 4 if available. We are not doing point of care lactate, so that will not be an indication. Capillary reperfusion greater than 3 seconds. Altered sensorium, thought not secondary to intoxication or head trauma, so an altered mental status. Or a witness PEA cardiac arrest less than 5 minutes of duration. And we'll cover that shortly. So 2 things to highlight in here is the capillary reperfusion greater than 3 seconds. So we want to make sure we're doing an actual cap refill exam on our patients to see how that perfusion is out to the fingertips. And then look at shock index. While this is not a current the vital sign, we want to be looking at the shock index. So that's going to be heart rate over systolic blood pressure. Anything greater than or equal to 1.0 is an indication of injury severity. So if you have a patient that has a shock index over 1, they are sicker and sicker as they get higher. And as you saw in the Broward County data, and as well as the New Orleans data, there is, a high likelihood of success with survivability with the patient in a high level shock index. And also by us giving blood, we can reduce their shock index from when we find them on scene to the time we hand off at the hospital. So in the cases of cardiac arrest, both medical and trauma, what we're going to want to do is, if we have a witness PEA cardiac arrest of less than 5 minutes duration, we can give whole blood. The witness can be any reliable source. And if the clinician suspects hemorrhagic shock etiology for the cardiac arrest and the patient is not in asystole, then the patient meeting above criteria should receive low titer O positive whole blood. So that means your patients that are in VFib or pulsus VTAC, PEA, and if you believe they have a hemorrhagic shock etiology, you can consider giving whole blood to these patients. As with all medications interventions, there are contraindications, but with whole blood, there are very few. One is going to be the patient indicates refusal to receive blood, and then a medical alert tag indicating patient objection to receiving blood. There are some religions that prohibit blood transfusions, so this is something you should be asking or looking for on your patient. So how are we going to actually implement this on the patient that requires it? So first and foremost, we're going to ensure that all hemorrhage and shock interventions have been taken care of. That includes tourniquets, wound packing, pelvic binding, and needle decompression. Then we're going to assess for any contraindications for low titer O positive whole blood. We're going to obtain IV access, 18 gauge or larger if possible, and then keep the IV catheter accessible to allow direct connection of blood tubing. A large bore IV extension set and large bore stopcock may be utilized if available. IV infusion is preferred over IO for optimal flow rates, but if all you can get is an IO, then IO will work. Transfuse a low titer O positive whole blood. In patients less than 35 kilograms, you're going to administer at a 10 ml per kilogram IO bolus amount. Anyone over 35 kilograms is going to receive a whole unit. Again, I'll apply a whole blood identification bracelet to the patient's wrist or ankle, and while it's transfusion, you're going to be looking for signs of reaction and then also signs of clinical improvement. For patients with non-compressible hemorrhage, look for signs of improved perfusion with presence of central pulses, but use the permissive hypotension approach still. Do not target systolic blood pressure of greater than 90 millimeters of mercury unless significant TBI. If inadequate clinical improvement, transfuse additional low titer O positive whole blood. Once again, with patients less than 35 kilograms, they're going to be administered 10 mLs per kilogram IVIO bolus amount, and anyone over 35 kilograms is going to get another whole unit. Once again, assess for transfusion reaction. Upon hospital arrival, inform receiving team of patient's receipt of whole blood and provide empty whole blood bags and any pre-transfusion blood samples if obtained for hospital blood bank evaluation. So, how will you, the field medic, know when to call for blood products? Prior to having to make that decision, there will be numerous trauma call types that will have an EMS duty officer dispatched from the beginning. This will decrease the amount of time it takes for the whole blood capability to reach the patient's side. Currently, there are no call types for possible medical patients needing whole blood transfusions, so your judgment as a clinician will play a major role in determining need for blood and when it will be initiated. All MCFRS paramedics are encouraged to use clinical decision-making and critical thought to best determine whether a patient will benefit from whole blood administration. A portion of that clinical thought is when to begin the administration. If the EMS duty officer is on scene for this decision, then the process can be initiated there or through the transport. In the case that the EMS duty officer is not present or is responding to the scene, you are highly encouraged to begin transport and rendezvous with the EMS duty officer and initiate administration while continuing transport to the hospital. The concept of marginal gains comes from the competitive road cycling world, and it pertains to a small amount of time spent in one area may decrease the amount of time in a future area, in the end buying time and leading to success. When applying marginal gains to whole blood administration, this small amount of extra time either on scene or pulling off the road for a rendezvous can buy your patient more time at the hospital. By delivering a patient that is better resuscitated due to whole blood, the hospital team can move faster to the OR or in turn ward off that almighty termination of the golden hour. Unlike other systems in the nation, MCFRS clinicians will not be limited in which hospital a patient receiving whole blood can be transported to. All trauma patients receiving whole blood should go to the closest appropriate trauma center to include MedStar DC, Suburban, Inova Fairfax, or Shock Trauma. In regard to any medical patient that receives whole blood, they can be transported to the closest appropriate facility, and it does not need to be a trauma center. To facilitate the physical administration of whole blood, EMS duty officers will carry the following: a cooler, a fluid warmer, low titer O positive whole blood, fluid infuser, and blood tubing. The cooler will keep the units of whole blood stored at the proper temperatures. The fluid warmer will warm the cold whole blood to body temp. At the start, duty officers will carry only 1 unit of low titer O positive whole blood. The fluid infuser will assist clinicians in rapidly infusing the blood into the patient, and the blood tubing is specific for blood administration. Currently, the only personnel that are authorized to administer low titer O positive whole blood to a patient are primary and backup EMS duty officers. The EMS duty officer will ride with you to the hospital, ensure all equipment works properly, and in the event of a malfunction, they can troubleshoot that problem. The EMS duty officer is not assuming primary care of the patient. They are providing an adjunct of care to the patient that you are the primary provider on. Logistics of handling the EMS duty officer vehicle should not deter you from calling for whole blood or deciding to administer it. Some of you may be wondering what will be the timeline for the units of blood within our system. The units that we receive from either Suburban Hospital or Inova Blood Services will stay with the EMS duty officer for 14 days. These will be cycled between stationary refrigerators and the coolers in the vehicles. At the end of the 14 days with the MCFRS, the units of blood will be returned to either Suburban Hospital or Inova Blood Services for usage within hospitals in the DC metro area. This is roughly modeled off of the timeline that San Antonio FD uses, where they have a less than 1% wastage since the inception of their program in 2017. The EMS duty officers will be solely responsible for all daily and routine checks of blood and equipment. Now that we've arrived at the end of this lecture, let's review the 4 objectives that we set out to learn in the beginning. Why are we deploying whole blood? Why are we using low titer O positive whole blood? What hemolytic reactions are possible? And how are we implementing this within the MCFRS EMS model? I hope that those questions have been answered, and the information that you've received better explains the program that we are rolling out with low titer O positive whole blood. Thank you for taking the time to listen to this lecture and understand the whole blood program within MCFRS. All questions should be directed to your EMS duty officer or the EMIHS office. Thank you for your time again.
Hello and welcome to the second portion of this month's video. It's a mix between a bunch of different topics that are good to review as we release whole blood into the field. So while Cook covered the actual whole blood program in the first presentation, in this section we're going to be talking about all of the other parts of treating a hemorrhaging patient outside of the administration of blood. So let's go ahead and get started. Taking a look at our objectives for this video, we're going to review BLS bleeding control. We're going to hit that pretty hard. It's something that paramedics don't review too often, but it does fit nicely in a video about bleeding and whole blood products. We're going to talk about what happens to your body when you lose blood and the compensatory mechanisms, kind of how they work. We're going to go over our treatment priorities, which is our MARCH algorithm or MARCH mnemonic. We're going to talk about all the ALS medications and how they kind of work with whole blood. And we're going to go over refusal of blood products and Jehovah's Witnesses and how we can best respect their beliefs while still providing ALS care. So what happens to your body when you lose blood? Well, your body tries to compensate and maintain perfusion to your brain and your vital organs. So we're going to look through a couple of different ranges of blood loss, and we're going to try to relate it to patient presentations. So when you see somebody who presents with an elevated heart rate, but let's say a normal blood pressure, you can have an idea of about how much blood they lost. So 0 to 750 patients will appear relatively normal. Heart rate, normal. Skin, normal. Blood pressure, normal. They should be alert and oriented times 4. To give you some reference, your average blood volume donation is about 400 to 500 milliliters. So give them some OJ and a cookie, like they do at the Red Cross, and these patients should start feeling better. Moving on to 750 to 1500 milliliters, this is where the compensatory mechanisms kick in. You're going to notice an increase in heart rate, an increase in respiratory rate, but the blood pressure is going to stay normal because this is compensated hemorrhagic shock. You move on to 1500 to 2000 milliliters. This is where the body's compensatory mechanisms start to fail and the blood pressure drops. So this is decompensated hemorrhagic shock. High heart rate, high respiratory rate, and low blood pressure, and these patients are going to be getting blood 100%. Moving on to 2000 plus milliliters, these patients are going to have super low blood pressures, high heart rates, high respiratory rates, and you're definitely going to start noticing some changes in mental status. Patients are going to be lethargic and confused. These people are very, very sick. So hopefully this gives you some type of idea as to between 0 and 2,000 milliliters how a patient progresses through the different stages of being able to compensate and then eventually decompensating into decompensated shock. So as medics, we all know that the real life-saving treatment provided to a hemorrhaging patient is those BLS bleeding control maneuvers. So we'll talk about in a couple of slides. The priority when caring for a trauma patient in the March mnemonic is always major hemorrhage first. And I know when I was originally taught bleeding control, it was kind of taught like a tiered approach. Like you show up and no matter what, you start with the hand over the wound and then you get your 4x4s and cling and do a pressure bandage. And then if that bleeds through and so on and so forth until you get to a tourniquet. So it's a great way to teach, especially somebody who has no medical training, right, coming into EMT school. But just a kind of a reminder that realistically, you want to start with the least invasive intervention that you think is going to control the bleeding on the first try. So if you're relatively certain that a pressure bandage is not going to work, just skip it and put on the next level up of bleeding control. You know, we don't want to waste time and waste blood messing around with things that we know aren't going to work. So we're going to go through each of these bleeding control techniques one by one. I think we can skip direct pressure with the hand. Everyone's checked off on that. And we'll start with the Israeli bandage. So our Israeli bandages are awesome. We've had them for a couple of years now. They're located in the black trauma bag in the center compartment. One issue with these, like all medical devices, is they come in multiple layers of difficult to open packaging. There's an outer and an inner vacuum sealed package on these things, and what I've seen a lot of people do is open both the inner and the outer while keeping the packages intact and then kind of reassembling it and putting it back together so that when you do have to use these things with blood or sweat on your hands, you're not messing around trying to get it open while your patient keeps bleeding. So that's something I've seen, and I think it's a pretty good idea. Now, in terms of actually putting these things on, you'll notice there's a couple parts to them. You've got the pressure clip, which is that little crescent-looking thing there. You've got the roll of gauze, and you've got that little string. The important thing to know with that string is it keeps the gauze roll together, and if you break it too early, it's very easy to have the gauze roll down your patient. So you're going to take that bulky dressing, put it down on the wound, and you're going to start wrapping. Here you can see break the string and do our first wrap. Once you get around your first wrap, you're going to go through the pressure clip and then back the opposite way you came. Be careful with how hard you crank down on these things. They can become a tourniquet if you're not careful. If that's what you want, then great, but just be aware that you can cut off circulation with these things. So once you go back, you're going to keep on wrapping. If at any point you decide that you might need more pressure on the wound, you can just do a twist like that and then continue wrapping. So you're going to wrap all the way down until you get to the end, and at the end of the bandage there's a little kind of two-sided clip with alligator teeth on each end, and you're going to clip it to the top and the bottom of the bandage, and it should hold it pretty securely in place, and that's how you put on your Israeli bandage. So next up is wound packing. Wound packing is for non-compressible areas like the axilla or the groin. Just like any bleeding, first thing we're going to do is put that gloved hand on it. After that, you're going to take a finger, you're going to put it into the wound cavity and try to feel around for the source of bleeding. When you find the source of bleeding, you're going to keep your finger on it, and you never want to take your finger off of it until you're done packing. You don't want to lose that culprit artery or wherever the bleeding is coming from. And then replacing finger for finger like we're doing here, you're going to pack as much hemostatic gauze into that wound channel as you can. And you're going to keep packing until it's completely filled up. Once it's filled up, what you're going to do is take whatever gauze is left over, if there is any left, and you're going to ball it up, put it on top of the wound, and you're going to hold very, very firm direct pressure with either the palm of your hand, your fist, or your knee for 10 minutes to let the hemostatic agent work. So this was taught to me, I can't remember who it was, but it was a military guy, and he said that when they would pack wounds, they were taught to take that roll of gauze and put it in their body armor so that they can pack down into the wound channel versus having the gauze laying next to the patient and kind of having to lift it up and put it down into the channel. So we don't have body armor, but we do have these sling trauma bags. So if you just take the Z-fold of gauze and put it into your trauma bag, you can pack straight out of the trauma bag, and it really is much easier to pack down into a wound than picking the gauze up off the ground and putting it in. It's also much more clean and sanitary. Give it a shot for yourself, see if you like it. I think it works pretty well. And then of course, 10 minutes of pressure afterwards. So while the application of tourniquets is pretty self-explanatory, one thing worth going over is how to pack them so that when you do need them, they open up and deploy pretty quickly. So one of the first things you want to do is take that little strap that you can mark the time on and fold it back and Velcro it to the same side that it's on so that you can get your windlass in and out very easily. Then give yourself about 6 inches of throw and it'll give you a loop that will fit over the majority of people's extremities. And then you're going to fold it in half where that buckle is, because there's Velcro on each side and it'll stick to itself and give you a nice tourniquet that stays together. It's very easy to pack and it'll stay in your trauma bag and deploy very well. So this is the bad tourniquet. We're going to kind of do a comparison of the application versus one that's packed in just a thrown in there type of way versus one that's packed correctly. I remember, I'm not sure if everyone else has seen it, but it was a common video showed in EMT class where there was a police officer taking care of somebody with a gunshot wound to the leg, and he is fumbling with that tourniquet, and for the life of him, he can't just get it open. And you see the blood puddle grow and grow and grow. And I remember that scaring me in EMT class. So one thing I always do in the morning is check out my tourniquets. So you can see that didn't take too long, but it didn't look like the most smooth application either. On the flip side, here's the one we just packed. Opens up into a nice fixed loop. You can throw it on. You've got plenty of throw to grab. And just like that, your tourniquet's applied. You can see how having that little time strap already back makes it so that you can throw your windlass right into place. And there you go. That's how you properly apply a tourniquet. All right, the old faithful March mnemonic. March is used to help providers remember treatment priorities when caring for a trauma patient. So number one is always control massive hemorrhage, right? A person can bleed out from an artery in under 2 minutes, which is why it takes precedence over airway in the setting of a massive bleed. So then once the bleeding's controlled, March pretty much falls back in line with the medical ABCs we all know, right? Get a patent airway, good ventilation, circulation is sufficient, skin, color, temperature, moisture, all of that stuff. Finally, March finishes up with a reminder to aggressively manage hypothermia and be alert for head injuries, where a single incidence of hypotension in a head injury can lead to a large jump in mortality. And remember, your head injury blood pressure is 110. Systolic is what you're aiming for. Now, one additional point on hypothermia before we move on from this slide is, while it's at the bottom of the list, it's an absolute killer of these patients, and it can and should be accomplished as early as possible, getting these patients protected from hypothermia, keeping them warm. So this is where you can divide your crew and do something kind of similar to what we do in codes with runners and clinical decision makers. So while you and the other ALS providers have your hands full, managing the hemorrhage, giving blood, whatever you're doing, maybe consider having a BLS provider assigned to like the keep patient warm duty. Get blankets, run back to the ambo and turn on the heat. One study of 2,000 people showed that accidental hypothermia raised mortality from 14.5% to 43%. So while initially it kind of seems silly to have an entire person dedicated to keeping the patient warm, that one BLS provider might actually be responsible for decreasing the mortality by 30%. So when you think about it, it's actually really good bang for your buck. So something I've been thinking about is how up until recently, IV access in hemorrhagic patients was not super important. I mean, I couldn't think of a single time that starting an IV on a patient in a trapped car or on the scene of a trauma was a super high priority for me. I mean, if I had to take a guess, 90% of my trauma IVs were started going down the road to the hospital. Because outside of small boluses of LR and pain meds, which have other routes, there was no real reason to rush and try to get one. But within the past couple of years, TXA and blood, and now there's life-saving interventions that can be administered once an IV is established. So maybe prioritize that a little bit more than we used to. Now remember that even though blood might be on the way in the duty car, until they get there, we should continue to use lactated ringers like we have been. Small 250cc boluses, maintain that blood pressure of 90 or 110 for head injuries. Finally, Cook touched on this in his presentation, but it's worth mentioning again and going into a little more detail. So one of the lethal processes that occurs in hemorrhagic shock, especially where massive transfusions are administered, is hypocalcemia. And this results because in the unit of blood, there's this thing called citrate, which is used to basically preserve and keep it anticoagulant. And normally the liver clears that citrate within a couple of minutes. However, in a patient who's in hemorrhagic shock, they're hypoperfusing, and they are getting multiple units of blood, multiple kind of doses of this citrate, this preservative. The lack of liver function causes hypocalcemia to develop because the liver can't deal and excrete that citrate. So the reason hypocalcemia is so dangerous is because calcium plays a crucial role in normal coagulation. And when a person's bleeding, we really want to promote and protect their ability to clot. So if you have idle hands while you're waiting for the duty car to show up, maybe consider getting a second IV started to give you a clean line to push calcium through when it's needed. So TXA has been in the protocol for a couple of years now. It's not a new drug anymore, but its scope has been getting a bit broader with the inclusion of postpartum hemorrhage as an indication, and they've opened it up to pediatrics a little bit as well. The dosing regimen, very simple, an adult dose being a gram mixed in 100 cc's run over 10 minutes through the IV pump. Both indications, shock and postpartum hemorrhage, require the delivery or the trauma to have been within the past hour. And they both require the patient to be systolic below 90 for adults or below the age-adjusted blood pressure for children less than 12. So real quickly, we're going to go over the pharmacology of TXA. I understand the clotting cascade is about as confusing as medicine gets, so I'm going to try to keep it simple and at a paramedic level while still giving you some useful information. So if you can remember back from whatever your initial program was, an agonist medication binds to and elicits a response from a receptor site, like fentanyl for opioid receptor sites, right? Fentanyl binds to opioid receptor sites and releases serotonin and dopamine and happy chemicals. An antagonist medication binds to and blocks receptor sites from being activated, like Narcan, right? It attaches to the opioid receptors and it blocks those happy chemicals from being released. Hopefully that sounds familiar because TXA does the same thing. It's a synthetic derivative of lysine that has a high affinity, meaning it loves to bind with and hold on to lysine binding sites on things called plasminogen molecules. I know it's a big word. You'll still understand. Now, when natural lysine attaches to and activates the receptor sites on those molecules, it reduces your ability to clot because it breaks down the clots. So TXA works kind of like Narcan does on opioid receptor sites. It attaches itself to those lysine binding sites, blocking them from turning it on. And this inhibits that plasminogen activation and results in stabilization of the fiber network and therefore stabilization of the clot. So simplified all the way down, TXA is acting as an antagonist medication, blocking receptor sites that when activated contribute to the breakdown of clots. Hopefully that made sense. Hopefully you enjoyed the video of me putting a TXA drip together. Thank you. So one of our field providers reached out to me through that training request jot form and made an awesome point. With the rollout of blood, we really need to remember that not everybody accepts blood transfusions. And I know Cook touched on it briefly in the first presentation, but the provider that reached out provided me with some great information and a few simple things we can do to prevent accidentally giving blood to a person who doesn't want it. So I would say most people know that Jehovah's Witnesses are a group who do not accept blood transfusions, but it's actually a bit more nuanced than that. So people who are a Jehovah's Witness carry this thing called DPA paperwork, Durable Power of Attorney, and it specifies their medical wishes if they're incapacitated, and they can also appoint a substitute decision maker if they are incapacitated. So there might be some slight variation in how the form looks, but from what I found online, this looks like the most common style of form, with the no blood down in the bottom left. Now that we know what to look for, it'd probably be a good idea to make a habit of checking the main places where advanced directive paperwork is located prior to hanging up a unit of blood. Kind of like to do in surgery before making the first cut, right? They make sure 10 seconds, is it the right limb, right patient, all that stuff. Do the same thing with blood. Take 10 seconds, I check their wallet, I check their phone, there's no metal alert bags or bracelets, and then go ahead and administer the unit of blood. So one of the things that provider sent me was a link to the Jehovah's Witness Medical Information Library. And it's actually really interesting. It's a site with a bunch of peer-reviewed journals that basically tell and teach medical providers how best to care for a Jehovah's Witness while respecting their beliefs. And there's plenty of information about bloodless medicine and TXA, some real good stuff, definitely worth checking out. Now the chart at the top right shows what may be acceptable and what's refused. And notice how it says potentially acceptable. it kind of hits on the main point, which is remember that people practice religion and custom to all different extents. Some people might feel that FFP adheres to their beliefs, and some might feel that everything on that chart is unacceptable. So make sure to ask. Basically, as a medical provider, the best thing to do prior to giving whole blood is to just tell them if they're awake. Get informed consent. It doesn't have to be long-winded. Just, hey, I need to give you a whole blood transfusion. And people who require blood transfusions are probably a bit out of it, so giving them the benefit of the doubt and actually face-to-face letting them know what you're doing is probably worthwhile. And then if they're unconscious or not able to make medical decisions, do a quick check, wallet, glove box, fridge, and make sure they're not carrying DPA paperwork and that they don't have medical alert bracelets or necklaces on them. Right? Finally, just remember, blood is contraindicated. It does not mean that we don't have all of our other medications and tools available. Continue to treat these patients to the fullest extent that their beliefs allow, just without the inclusion of blood. I know it was a bit of a mishmash of topics surrounding trauma and blood, but hopefully you found some of this information useful, and thanks for watching. Like I spoke about in last month's video, these 3 QR codes are going to be included at the end of every video going forward. So if you have an idea for EMS training, please scan the one on the left. If you have any type of feedback, good or bad, about the content we've been putting out, please scan the middle one and let me know. And if you're interested in teaching or creating monthly video segments yourself, scan the one on the right, and I'll be happy to get you involved. That's all we have for the August 2024 Medic Monthly video. I hope you all learned something. I hope you enjoyed the content, and we will see you next month.